Imagine a healthy 25-year-old, no recent surgery, no prolonged immobilization, no cancer. Yet they suddenly develop a massive deep vein thrombosis in their leg. The standard medical protocol for an unprovoked blood clot is straightforward. Administer a routine, life-saving anticoagulant like warfarin. But within days of starting this treatment, the clot doesn't dissolve. Instead, the patient develops severely painful skin lesions that rapidly progress to massive hemorrhagic tissue necrosis. Across the clinical spectrum, a seemingly related extreme event occurs. An infant is born with widespread simultaneous blood clots, destroying their microvasculature, a fatal condition called neonatal purpura fulminans. Why does a young, healthy patient suffer such a catastrophic clotting failure? And why does giving them a standard blood thinner trigger rapid tissue death? The answer traces back to a genetic breakdown in the body's endogenous negative feedback loop, specifically a deficiency in protein C and protein S. Treating these fatal complications requires moving past basic memorization of the coagulation cascade and analyzing the precise pharmacokinetic traps hidden within the human clotting system. Following a vascular injury, the coagulation cascade produces thrombin. Thrombin is the aggressive driver of clot formation, rapidly converting fibrinogen into a solid fibrin mesh. But thrombin's role completely changes the moment it leaves the injury site and reaches an intact endothelial cell. Here, it binds to a specific membrane receptor called thrombomodulin, triggering a distinct structural change. This binding event inverts thrombin's function. It stops acting as a procoagulant and instead cleaves a circulating inactive precursor protein, turning it into activated protein C. Activated protein C is a potent anticoagulant, but it cannot function efficiently on its own. It requires a physical structural support to halt coagulation. That essential cofactor is protein S. Together, they form a complex that actively hunts down and dismantles active coagulation factors VA and V8A, permanently shutting down further thrombin generation. However, there is a strict bioavailability constraint on this system. Only 40% of circulating protein S is free and biologically active. The remaining 60% circulates tightly bound to C4b binding protein. In this bound state, it is completely non-functional for anticoagulation. When patients inherit mutations in the PROC or PROS1 genes, they lack the functional proteins required to execute this braking maneuver. Without activated protein C and its cofactor, factors VA and V8A survive unchecked. They enter a runaway positive feedback loop, churning out massive amounts of excess thrombing. A normal, localized clot designed to stop minor bleeding becomes a systemic, hypercoagulable threat the exact moment this specific braking mechanism is compromised. While severe liver disease can cause an acquired deficiency of these proteins, the primary clinical danger lies in inherited autosomal dominant mutations. In the heterozygous state, a patient inherits only one defective copy of the gene. They still produce enough functional protein to manage daily minor vascular injuries. Because of this partial function, heterozygous patients generally remain asymptomatic throughout childhood. Their deficiency only becomes apparent in adulthood, when they suddenly present with an unprovoked deep vein thrombosis or pulmonary embolism. The extreme end of the genetic spectrum occurs in patients with rare homozygous or compound heterozygous mutations, where both inherited gene copies are defective. This homozygous state completely eliminates the protein's presence in the blood. The hypercoagulability is absolute, and it manifests immediately at birth. This total deficiency presents as neonatal purpura fulminans. Without any natural anticoagulant breaks, countless microclots erupt simultaneously inside the infant's microvasculature, instantly blocking fluid flow. A patient's genetic zygosity acts as a strict volume dial for their baseline hypercoagulable risk. It dictates whether they will experience their first severe clot at age 25 or within hours of birth. This brings us back to the clinical paradox. Why does administering the anticoagulant warfarin to these deficient patients cause catastrophic tissue necrosis? Protein C, exactly like the procoagulant factors 2, 7, 9, and 10, relies entirely on vitamin K for its synthesis in the liver. Warfarin works by blocking vitamin K. This intentionally shuts down the liver's production of all these clotting and anti-clotting proteins simultaneously. This graph tracks the plasma concentration of these proteins over the first 10 days of treatment. The divergence occurs because these factors do not clear from the bloodstream at the same rate. The procoagulant factors have long biological half-lives. As you can see, they degrade slowly in the blood over a period of several days. Protein C, however, has an extremely short half-life. Its plasma concentration plummets to near zero within the first 24 to 48 hours of starting warfarin. This creates a severe disparity between days 1 and 4. This marked gap between the crashed protein C line and the high procoagulant lines forms a dangerous, transient hypercoagulable window. Physiologically, this means warfarin completely strips the blood of its natural braking system days before it successfully halts the procoagulant factors. If you apply this pharmacokinetic model to a patient who already has a genetic protein C deficiency, the danger multiplies. Because they start with an artificially low baseline of protein C, the rapid warfarin-induced drop leaves them with absolutely zero biological defense against clotting, while procoagulant factors remain high. During this critical unprotected window, rapid microthrombi violently occlude the blood supply in areas rich in subcutaneous fat. This total microvascular occlusion is exactly what causes the acutely painful hemorrhagic skin lesions we identify as warfarin-induced skin necrosis. Warfarin-induced skin necrosis is the direct result of these mismatched protein half-lives, a predictable pharmacokinetic failure. Diagnosing an inherited thrombophilia requires navigating these exact biological traps when a patient presents with an active blood clot. Looking at the standard clinical flowchart for venous thromboembolism, there is an absolute diagnostic rule. Clinicians must never test protein C or protein S levels during an acute thrombotic event. An active clot consumes circulating anticoagulant proteins. Also, if on warfarin, synthesis is blocked. Testing now guarantees a false positive diagnosis. The correct protocol is to wait until full recovery and pause anticoagulation before performing functional assays. When assessing a hypercoagulable state, this matrix shows how protein C and S defects differ from other thrombophilias. Protein C targets factors VA and 8A, risking warfarin necrosis. Antithrombin deficiency directly inhibits thrombin and factor XA, presenting with heparin resistance. Because of the hypercoagulable window we mapped earlier, immediate management for acute events requires therapeutic anticoagulation with heparin or low molecular weight heparin to safely bridge the initial risk period. For long-term maintenance, adult patients are often transitioned to direct oral anticoagulants, or to warfarin, provided it is introduced with days of careful heparin bridging to prevent skin necrosis. In severe acute scenarios, like neonatal purpura fulminans, the missing proteins must be immediately replaced using fresh frozen plasma or specialized protein C concentrates to save the patient's life. Treating protein C and protein S deficiency requires seeing past the physical clot. Clinicians must master the underlying molecular braking systems and pharmacokinetic timelines to avoid critical diagnostic traps and prevent catastrophic clinical errors.